All right. Well, welcome to this webinar hosted by Able Americans. You will have a Q&A button on your Zoom function that will allow you to put questions. So as we go, feel free to drop questions in the Q&A box. And at the end of the presentation, I will go through them. So this webinar is being recorded for participants to see afterwards and to send out. So you'll be able to find this in the slides in our follow-up. But I am Rachel Barkley, the director of Able Americans. Able Americans is a nonprofit, nonpartisan think tank project of the National Center for Public Policy Research. We are dedicated to advancing innovative free market solutions that empower Americans with intellectual, developmental, and physical disabilities. We advocate for policies to remove barriers, expand individual freedom and choice, and deliver better outcomes for people with disabilities and their caregivers. Our mission is rooted in the belief that opportunity and human dignity are part of the American promise for all people, regardless of ability. One in four adults in the US live with a disability, and the total number of Americans with disabilities and their caregivers now exceeds 100 million people. So, this is critically important we get these policies right. I know personally that anyone can become disabled any day. I became disabled 7 years ago when I acquired a spinal cord injury. And so, as director of this project, I'm very passionate about even people who don't have someone in their family understanding how these policies work. So, today we are going to be going through a very timely topic and our new paper addressing fraud in Medicaid home and community based services. From here on out, I'll call that HCBS, so Home and Community Based Services is HCBS, and that's how everybody will be referring to the program because it is a bit of a mouthful. So today I will go through our agenda here. So first, we will have the wonderful Sarah Hart Weir, who is the executive director of the Kansas Council on Developmental Disabilities, giving us an overview of HCBS and what that provides to people. She is the former president and CEO of the National Down Syndrome Society. During her tenure, she led the passage of the landmark Bipartisan ABLE Act in 2014 and helps individuals navigate programs and supports every day in her day job and really understands how Medicaid HCBS works for people. She's also a senior fellow with Able Americans and helps us do this important policy work. After we hear from Sarah, we will hear from TK Small. And TK will share his lived experience. He has been an attorney since 1994, focusing on healthcare policy and disability law. Between 2013 and 2022, he was the director of policy for Concepts for Independence, Inc., a Medicaid funded provider of consumer directed personal assistance services, which, if you don't know what that is, you'll learn more about it during this webinar. Currently, TK works for a not for profit healthcare company in their government affairs department, providing lobbying assistance and operational advice related to members with disabilities. His interest in HCBS is both personal and professional, so I'm really glad he's here to give his experience. As he has had a significant lifelong disability and spent 9 years in a rehab hospital for kids. TK works full time. He lives independently with a dedicated team of personal care assistants. So we'll hear about his lived experience. Then we'll come back to just some context about the fraud conversation that's happening, and we'll finish with solutions to prevent fraud, waste, and abuse from happening. And we'll hear that from Les Ford, who is a senior fellow with Able Americans. She has a broad bench of policy experience, has worked in the Senate and in the White House Domestic Policy Council on these kind of solutions to fix the social safety net for those who need it. And she has been doing this work for almost 2 decades. So, with that, I am going to kick it over. Well, first, I'll show you this is our report here. You can find it on our website via this QR code or the address there. So, please do download the report. But I will kick it off to Sarah to give us an overview of HCBS. Go ahead, Sarah.
Thank you, Rachel, and really excited about today's conversation and some of the ideas and concepts we have here moving forward. But before we kind of dive into the policy recommendations and leaning on TK's expertise, we really wanted to start by grounding this conversation in why home and community-based waiver services, or HCBS, as Rachel pointed out, matter deeply to millions of Americans with disabilities and their families across the country. As many of you probably realize, Medicaid is a pretty old program. It was created in 1965 as a healthcare safety net program for Americans. But for people with disabilities, at the time, there was a major flaw in that original design. If you needed long-term supports, those supports were largely available and tied to institutions in the United States. So, what that really meant was that people often had to leave their homes, their families, their schools, their jobs, and their communities just to receive care. HCBS in the 1980s really changed that paradigm for Americans with disabilities. In 1981, Congress created the 1915C Waiver Authority under President Ronald Reagan. And by 1983, states could begin offering services in people's homes and communities instead of institutions through these waiver programs. At its core, HCBS is really about dignity and independence and community integration for Americans with disabilities all throughout the country. If we go to the next slide, we're going to talk just briefly about how those supports work. Home and community-based waiver supports support millions of Americans with disabilities through specific services, and we're going to highlight a few of those services on this slide. We talk a lot about this throughout the country in the work that we do, but those services, those waiver services, range from personal care attendant services, residential supports, day and employment services, respite care, behavioral and clinical supports, case management or service coordination, depending on the state you live in, home and vehicle modifications that allow individuals with disabilities to modify their homes and their bathrooms in the way they access their own homes and communities, vehicle modifications to get to and from work, and assistive technology. One of the things you'll hear from our colleague TK here shortly is about his experiences navigating HCBS personally and professionally. And before we do that, I just want to point out a couple other important elements of the HCBS system. HCBS is also significantly less expensive than institutional care. In our recent report, you'll note that HCBS costs less than one-third of the cost of institutional settings. But despite its success, the system is under enormous strain. Across the country, we have more than 700,000 Americans who are currently waiting for HCBS waiver services. And most of those individuals are part of the community that I've represented and worked with for the last 20 years. And those are individuals with intellectual and developmental disabilities, as we note in the publication. Each day, I have a front row seat to seeing how this system puts a strain on being able to serve Kansans with intellectual and developmental disabilities. In our home state, we actually have nearly 4,900 individuals or Kansans who are currently waiting for IDD waiver services under our HCBS system. And many of those individuals are waiting 8 to 10 years for that support. So let's think about that for a moment. A child who is entering elementary school and goes on the wait list, when they transition into adulthood, or the cliff as we often refer to it in the disability community, that individual is still in Kansas going to be waiting for those services as an adult. These are not abstract policy numbers. These are real families. And in Kansas, we're advocating every day with our legislature, with the governor, and our state agencies like the Kansas Department for Aging and Disability Services, or KDADS, to bring that wait list down to zero. I think about one family in Kansas that I've been working with very recently who has a son who has autism, and that individual requires significant daily support. His aging parents are providing nearly all of his care. And because there are no waiver services available and he's on the waiver wait list, those parents constantly worry about what's going to happen to their son if one of the parents gets sick, injured, or passes away before those services arrive. That family spends the majority of their time not being able to serve and adequately support their son, but they're in survival mode. They're patching together care, managing crises, and trying not to burn out while they wait for a system that was designed to help them. The other thing that really isn't measurable and really is an element of why these waiver services are so vitally important, and that's the emotional exhaustion and those human stories that sometimes policymakers often do not fully see. Um, on top of navigating the system, families are constantly get navigating complicated eligibility systems, annual redeterminations proving that they have a disability that they were born with, and inconsistent state rules. And on above all of this, there's long periods where there's little transparency about where that individual even falls within the waitlist timeframe. The vast majority of families are simply trying to care for their loved ones and keep them safe and integrated into their communities. So, as we discuss oversight and accountability today, we also have to remember the original purpose of HCBS, and that's to allow people with disabilities to live full lives in the places where life actually happens, and that's at home, at work, and in our communities. For many families, access to these services is not a policy debate, it's the difference between stability and crisis. I'm going to turn it back over to Rachel to continue us on.
Thank you so much, Sarah. This is so critically important to understand what the day-to-day looks like as an individual who has to navigate HCBS, which is a state administered program. So every state is different in what their rules have and what they provide. So I appreciate that look at what that infrastructure looks like. Our next speaker, TK, is going to give us a lived experience as somebody who benefits from the HCBS services to have his career and his life. And TK is going to tell us more about that. Before I kick it to TK, I want to remind the audience that you can put questions in the Q&A throughout the presentation, and we'll get to them at the end. So with that, TK, I'll hand it over to you.
Well, thank you, Rachel, and thank you to Able Americans and the National Center for putting this important work together. I think it's very important that people with disabilities be part of the conversation and at the table. And what I really think is so important is the emphasis on freedom and independence and trying to find creative uh, uh, market-based solutions to help people with disabilities live their own version of the American dream. I've been fortunate in that I have a career and I make a halfway decent living, but I really attribute that to the availability of HCBS. I live on my own in my own apartment here in New York City, surrounded by 8 million other people. And if it wasn't for my team of caregivers, I couldn't do any of that. I happen to be on the more expensive end of the continuum in that I have a rare neuromuscular condition called spinal muscular atrophy. For the most part, other than speaking and sharing my ideas and doing some writing, I need total help with everything. So I have a dedicated team of people that come into my home. I do all my own recruiting, training, scheduling, occasionally terminating of the personal assistants, which is what we call them here in New York State. And I am fully responsible, which is the essence of what personal responsibility is all about. I developed a strong relationship with these people, and over the years, they've lost parents. I've buried two parents myself, and they are as much, they're, in many ways, they're more of a family to me than actual members of my family. I am very close to them, and they are dedicated to me in the same way I'm dedicated to them. They help me with everything from laundry to cooking to shopping, complicated care, things related to my health and my trach, etc. They help with my ventilator. They help travel me around all over the country, around New York State, to and from the office as I need to get in there. So I'm only able to do that with HCBS. And here in New York, we have two different models of care. So I use the one that allows me more freedom to do what I want. But the other type of care is what they call agency based or more of a medical model. And that's where there's a agency that sends workers to your house. That's good for some people that don't have complex needs like mine. But excuse me, uh, with the program that I use, it used to be with a company called Concepts of Independence, and so under that program where you're completely responsible for your own care, every person runs their own life differently, and so what is freedom for one person is going to be a different version of independence for another person. That's the type of program that I use, and it really is important to allow somebody to stay in the community, to have a job, to have a relationship with another person. It allows real freedom for the individual. And so on that, I think I will say that's what uh, HCBS can provide. And I will kick it back to Rachel.
Thank you so much, TK. I just, took some notes while you were talking here about, we talk a lot about a program run well should hit certain kinds of outcomes. And I think you hit exactly what outcomes we're looking for. Freedom of choice and independence, to be in community, to have a job and work, and to be in relationship. And that is the ideal of what we're looking for in our social safety net programs. That is the purpose, the core mission of HCBS, and something the HCBS program should be proud of, and that it's just a support to allow you to build your life. So thank you for that kind of bird's eye view. Um, Now, from here, now that we've understood the core mission of HCBS Run Well, we are going to kind of talk about what has been going on in the news and kind of dominating headlines lately in DC, which is cases of fraud and the fraud task force that the vice president is leading, that is undercut, finding fraud, rooting out fraud in these programs. So in our paper, we wanted to make sure that we broke out fraud, waste, and abuse because these are different concepts. And often all three get talked about with just the moniker of fraud. So I'm going to briefly go through what fraud, waste, and abuse is and what some of these high profile examples have been in the news. Because we think it's critically important that states and the federal government get these fraudulent cases under control and prevent them from happening in the first place. Because as we'll see in these examples, if fraud is allowed to take root for years on end, it's really people with disabilities and the most vulnerable among us that are hurt. Because these fraudulent providers really prey on not having oversight on their activity. And I want to emphasize as we get into this that when we're looking at these fraud, waste, and abuse cases, it is almost always the provider. And we say provider, these are the third party service providers that are committing these cases of mass fraud. We're not talking about individuals with disabilities. So that's a really important distinction as we get going here. So you'll see the definitions of fraud, waste, and abuse. Fraud is illegal activity. It's people purposefully billing for services that are never delivered, and it causes real extreme harm to people. Waste and abuse are different categories that can be legal parts of the system, but it's not good for a flourishing system to use our dollars well. So, waste is when resources are not used in the best way possible. And this ends up in these long wait lists for people waiting for care that Sarah talked about, or stretching the program too thin that you end up in fiscal problems in states and at the federal level. And lastly, we'll talk about abuse, where things might be legal. Somebody might find a loophole in policy and be able to kind of work the system legally and abuse the letter of the law by inflating rates over what's fair just because Medicaid allows it or there isn't oversight at the state level, or even political misuse of the funds. So you'll see some examples here at a high level of fraud, waste, and abuse, but I'm going to go into the specifics in the next slides. So first we're going to talk about fraud, which is the illegal activity that's really in the headlines that is shocking and really should make us all angry because it is stealing money from people who need it. So the first story, these are both from Care, Care 11, which is a local news source in Minnesota. Minnesota's been at the top of the President's Fraud Task Force. And so I wanted to tell two stories that have come out of Minnesota. First, on the left is Janelle Sky Hansen, who is a young woman with autism, and she had a provider who was billing for daily care but not providing it. And when investigators came to kind of crack down on this fraudulent activity, then what happened was she got evicted for her provider's misuse and fraudulent billing of Medicaid. She was collateral damage in this fraudulent provider's case and ended up homeless on the streets because in her particular waiver, her housing was covered in this support. So it's a terrible, tragic story that she was collateral damage of. The next story is incredibly sad that just came out and the Fraud Task Force has been talking about. And this is Rick Clemmer. And he battled serious mental illness and substance abuse for a lot of his adult life. And he also was on the same waiver that Janelle was on. And in the ICS waiver, he had his housing covered, but he also had this provider who was billing 12 hours of care a day at $461 an hour. Um, so sad. He was found in his apartment deceased. And meanwhile, the day before, the company was billing for 12 hours of care that they were not providing. They were not there every day for 12 hours a day. And so his life was again collateral damage to this fraudulent company that then has been charged for billing for services that they just are not providing for people. So these are very sad stories out of Minnesota. That's the human cost of fraud there. When we talk about the next category is categorized as waste, which is, maybe not even purposeful, but designing program eligibility and program incentives in a way that stretch dollars so thin that it puts at risk the program for people who really need it. And so here you see in New York, the orange graph here is showing New York compared to all other states and the per capita home health workforce. So you see this huge increase in New York's home health caregiving workforce, and this happened through kind of a confluence of policy, maybe misincentives and changes. This program that allowed consumer-directed care, person-directed care, had been in place since 1995, but it had this huge 250% increase from 2018 to 2024. Some things that contributed to this were at the same time in 2016, there was an increase in the minimum wage and the allowance of family caregiving that kind of incentivized more people to enter that field, which is a needed and good thing. But when there aren't guardrails on who's eligible for these services, you can see this kind of ballooning. And so in New York, some of these guardrails came off when those who are eligible they lowered the threshold for those who are eligible. So people who only had one activity of daily living. So TK talked about, he has things from cooking, shopping, his trach, his ventilator, travel, many activities of daily living that he needs. New York lowered the threshold. So somebody that only had one of those needs could apply. And so that's really at the core of the problem. So an incentive for more people to sign up to be caregivers as family caregivers, et cetera, but then also lowering the threshold. This was all done legally, and that's why it's waste and not fraud. Last is abuse. So there was a person in the state of Indiana who saw a loophole in the Medicaid system, and they set up a business and charged exorbitantly high rates, $640 an hour for autism services. This one center was far off what the mean or the median of payments should be. And the Wall Street Journal uncovered this, that the owner was making huge profits off of this and was charging far too much, and had no state oversight that caught her doing this. And the Wall Street Journal uncovered it, and the state cracked down and stopped paying it. But this is an example of abusing the system. So now that we've talked about what fraud, waste, and abuse are, um, I'm sure you feel as mad as I do that people have taken advantage of the system, because we know how much people really need these supports. And at the same time, we have 700,000 people across the country on wait lists waiting for them. So, what can we do to prevent this from happening in the future? All of the panelists today have contributed to these solutions, and many others around the country contributed to this report. So I'm going to go to Les Ford next, who's going to walk through what these six, sorry, not three, six buckets of solutions are. Les.
Great. Thanks so much, Rachel. And as I go through these six solutions, I'm going to go into a lot of details. But at the top, I want to point out that these are primarily directed at Congress, but these can also be administrative solutions. So CMS can take a lot of actions to implement these solutions. And while we're primarily looking at a lot of administrative, congressional authorities here, if you're at a state level, you can also HCBS is a state waiver. States oversee the program. So states can take the reins to implement any of these solutions as well. They are not unique to any state actor can implement these solutions. So let's dive into it. First is just increasing transparency. One of the things we hear anecdotally from individuals on the ground in almost every state is there's just not enough transparency. They don't know what providers are available to them, how much those providers are charging the state for their services, when those services are available. So, our recommendation is that the state and CMS should be demanding of the state that there should be public dashboards. The first public dashboard should be that every wait list across the country needs to be public. An individual who signs up on a wait list should know where they sit on the wait list. They should know when they're going to get off the wait list. They should know when they're moving up the wait list. If you are going to move state to state, if you are currently in Ohio receiving HCBS services and your parents are thinking of retiring to Florida and you would like to think about moving to move to Florida with them, you should be able to look online and say, if I move to Florida, how long would it take for me to get off of Florida's wait list? This should not be an opaque process. It shouldn't be on an Excel spreadsheet somewhere. There should be transparency. It should also be very transparent what the eligibility for getting HCBS services is. In New York, for instance, the requirement that it only was one ADL was actually very opaque. Many people only learned that New York only required one activity of daily living when they switched it to three activities of daily living. The eligibility for individuals for who can receive these services should be right there um, on the state website. And that really allows us to see, is the state really focusing on an individual with severe disabilities, or are they broadening their eligibility so wide that they're increasing costs and not really focusing on those with severe disabilities? And finally, we should know how much they're spending per provider, per service. Anyone who has a severe disability knows they don't see that. They might be assigned a provider, they might be assigned a service. They don't know necessarily how much someone is billing. A lot of the families who received autism services in that Indiana case had no idea that when they were bringing their child to receive autism services, that they were being billed $640 an hour for their child to sit there for an hour. And in some cases, they were just watching a movie. So there should be radical transparency with spending. Um, there should be provider directories with these services and rates. Most importantly, there should be standardized whistleblower and reporting systems. Now, if you go on to Medicaid's Center for Program Integrity website, there is a whistleblower button. Before this administration, there were only 6 people who worked in that department. If you filed a whistleblower claim, you never knew when or if anyone would get back to you. Most states would not get back to you. So there should be a standard reporting system, and you should know when someone's going to get back to you if you file a whistleblower claim. The second thing, the second category, the second bucket is strengthening CMS oversight and accountability. A lot of what we're seeing in these fraud, waste, and abuse systems is states taking their eye off the ball. And again, this is a hard system to keep track of. There is a lasagna of providers in between the state and the individual with the disability. This requires an intense amount of accountability and oversight. So first is establishing eligibility guardrails. The point of this system is for individuals with severe disabilities to be able to stay on their homes. And eligibility guardrails focusing on the highest need individuals is the focus of the system. CMS should be ensuring that they know what every state's eligibility system is and establishing guardrails around that. Second, CMS should be auditing high cost and outlier services. Every state on a quarterly basis has to get reimbursement from CMS for every single provider payment they send out. CMS should be analyzing all those provider payments and flagging anything that's an outlier. Finally, CMS should be enforcing state performances. And they can be doing that using AI. And there are many reports on how they will be using artificial intelligence to analyze state performances to ensure that they are focusing on those with the most severe disabilities. Three, we need to be modernizing our fraud detection. That same system, the national data systems that states use to receive payment from CMS, is called TNSIS. And we can be using that for predictive analytics to see where those radical departures from the norm are. That's predictive analytics. That shows us where the fraud is. A part of that is using third-party auditors. Only 16 states currently use third-party auditors. Before the ACA was passed, every state was required to use third-party auditors. We should reinstitute the practice of third-party auditors. It's not enough for a state to hold itself accountable. We need a third-party system to come in to look at the state books to say, is something out of line here? Finally, in modernizing fraud detection, we actually put in place something called electronic visit verification in the 2018 Cures Act. I'm sure if you use HCBS, you've dealt with the system. When a care provider comes in, they're supposed to make sure that you sign off that they're here. This is the date. This is the service provider. We've got the basics of that in place, but it is not well documented. All CMS has really implemented in this is that states have kind of set up a system, but states are not sending that data up to CMS, and CMS is not analyzing that data. So we are not actually using that data to see whether fraud is actually occurring. We've just set up a system and said, oh, it's there. So we can create a modern fraud detection system, and we should. 4, the point of HCBS services is the person with a disability and their family. That is the point, is to serve them, to ensure that they are able to live in their community. So we need to ensure that we are empowering them, not providers. What I just talked about, electronic visit verification, we need to ensure that every person has access to their own EVV data. And right now, CMS does not require states to ensure that individuals with disability have access to their own EVV data to ensure that the provider is getting it right and to correct that data. That should be a non-negotiable. That is the standard across every other electronic record, and an individual with disability should have that same standard. Secondly, like this model that TK uses, we need to expand self-directed care models. No one should be at the mercy of, this is your provider, this is your service, this is your only option. And too many families across the country are on that secondary model. We need to shift the power from systems and providers to recipients while still ensuring that they get the best care possible. Which leads me to reform number 5, which is measuring outcomes, not just spending. A couple of years ago, we actually dumped a lot of money into the system, about $34 billion. But with that tons of money increase, we didn't actually say, here's what we need to see change. Here are the outcomes we expect states to increase. We need to track whether services are actually delivered. We need to track whether states are focusing on those with the most severe disabilities. We need to set out the goals we expect for those individuals with the most severe disabilities and track whether states are meeting them, whether providers are meeting them, whether personal care services are meeting them. This can be a simple outcome as, are you clearing out your waiting list for those with intellectual disabilities? That's an outcome we can all track. So measuring outcomes is number 5. And 5, we need to rein in third-party provider misuse. There's a variety of provider misuses. I'm just going to go through some of them. We know they're using Medicaid funds for lobbying. That needs to be absolutely banned. We need to require full ownership transparency. In the private sector, you have to be very clear, if you are a publicly traded company, the full ownership group. That should be also clear in this space. You shouldn't be able to have multiple nursing practices or multiple provider groups. We should know if you're the owner of this provider group or that provider group. We need full transparency. This allows us to address conflicts with third-party intermediaries. And finally, we need to ban mandatory dues skimming. A lot of states are requiring personal care service workers to join unions, even if they don't want to, and that should be banned. So these are just 6 common sense ways to prevent fraud, and most importantly, to protect this program for those who is intended to serve. Passing it back to Rachel.
Thank you, Liz. And I'm actually going to jump right into Q&A because we had a really good question from Linda in the Q&A box that, stated the very high Texas waitlist numbers, lots of people on the wait list, and some waivers have very low wages attached to their caregiver reimbursement. And I think, Les, your solutions hit on how to address this through some of these. We talk about them in the context of fraud, but if we require CMS to say, all right, what are your outcomes? Are you helping people move off the wait list into care? Are you having transparency on your wait list of where you're at and how much providers cost? That is a solution to this. But I want to throw it to our 3 panelists here on this question from Linda.
Yeah, so I'll say CMS doesn't have the current statutory authority to tell Texas you have to set this rate for your provider wages. However, some of the solutions we've discussed today, for instance, setting the outcome for, hey, this is your outcome for waitlist, or setting this transparency for, if you like your 1915C waiver approved the next time, you need to have a transparent dashboard on your wait list and how much you're paying providers and your service rates. That would do a lot to ensure individuals, especially those approaching that cliff, that 18, they're off the wait list and they're into care sooner, so that the parents don't have to take that $12 an hour rate. Those might be some solutions in the interim. But I know Sarah probably has some solutions as well.
Definitely. I mean, on the grassroots advocacy perspective, I really encourage advocates in those states to pay attention to how those rates are set. Typically in Kansas, those are set by our legislature and reviewed obviously on an annual basis. And a lot of these legislative sessions, as Les and TK and Rachel know all too well, go really, really fast. They're a lot shorter sessions than Congress, which are typically, working throughout the year. And so a lot of these rate policies are set, in the dark times of the night. And it's really important for advocacy organizations to pay attention to the conversations that are happening, to be active at your state house, making sure you're testifying and talking about the needs and supports that you as an individual with a disability or your family members need in order to be successful. I know in Kansas, that's something that we pay very, very close attention to. And then, as Les knows, every once in a while, states will also do rate studies, and that information should be publicly available as well.
If I could supplement what Les and Sarah mentioned, I don't really have an answer to the Texas situation. If I had my ideal situation out there, it would be something like a cash and counseling type of program where the individual or the family gets given, they do a calculation and are provided with a bucket of money, and how that gets spent is up to that person individually, because certain things are more important to me. I would pay more for them and have less of something else. That's the epitome of freedom. I think it would eliminate a gigantic bureaucratic budget line, and I think it would be more efficient if you have the right people in the program. Whether that helps the situation in Texas or not, I don't know. But where the family can spend the money exactly how they want, as opposed to a system saying, oh, you have to spend exactly $12 per hour for this or $20 for that. No way. I think if the right people are running the program and the right people are in the program, it should be great.
That is exactly right, TK. You nailed it. And that's our point number four, empower individuals and families to make these choices. And that's, I think, the core of the solutions here. So thank you for adding that. Our next question from Linda is really important. And I think, part of the reason we wrote this paper, Linda, her question is the bulk of fraud, and kind of a statement here, the bulk of fraud is by large providers. Those two really terrible cases I went through, it's because of the providers, not the individuals. Yet some in the media are casting this as family fraud or, done by an individual. How can we change the incorrect public opinion on this? Any of our three panelists can jump in on this.
I think that's a really good question. And I think that'll be part of this discussion is bringing out individuals as people who are caretakers for individuals with severe disabilities or individuals who have severe disabilities like TK, telling their stories in public about what it's like to live in that situation, what it's like to have someone with cerebral palsy in your family and trying to navigate this system and contrasting that with the stories of fraud that we see. The stories of fraud are the providers. It's someone who's taking advantage of a system that's difficult to run. And we do have to contrast that quite openly. And my fear is that this fraud conversation turns against a program that's so needed. And so I think it's being vocal and about the reality of life. And I'm not saying that's easy.
And I would add, and Sarah and TK jump in here as well, but I would add that I think that disability advocates, I know like my instinct is, hands off, don't touch this program. And I think that we have to um, be willing to say, let's all come together to find the fraudulent actors and not pretend this is not a problem because it clearly is a problem. These, fraudulent providers do exist. So we, as people with disabilities, are the victims of these fraudsters as well, and people abusing the system as well. And so I think we have to be at the table, like everything. We as advocates have to be at the table and not pretending that the table isn't happening, which can be easy to do. So I think, the hard work of showing up and participating in this fraud discussion in your state and, reporting fraudulent activity and all of that, I think is important.
And just to jump in here and echo exactly what Les and Rachel said, I think the individuals that have the lived experience and family members that are navigating these waivers and these government-run systems know where the system is broken. And I think on top of coming to the table and offering solutions to strengthen HCBS, not take it away, is truly important. That on top of making sure that the funds that support waivers and just Medicaid in general actually go to the individual. And oftentimes in our federal and state work, we see a lot of silos. We see a lot of barriers in terms of how these programs are run. And I think our goal here is to simplify the process for self-advocates and families so that they're navigating, one front door for services versus, 11 back doors to get waiver services or just government supports in general. It's something we're really focused on in Kansas right now. We have almost 11 different state agencies that touch the disability system. which provides a lot of complexity and a lot of breakdowns when it comes to actually supporting the individual.
As a practical observation of how advocacy occurs, etc., it's so easy to get overwhelmed by what's going on. I would say that my advice to people that are interested in making a difference is just keep plugging away, stay involved, and reach out to people that you find are sensible, like able Americans, in terms of just becoming part of small grassroots organizations. I mean, is doing so much in Kansas, and like it starts with two parents or two people with disabilities just saying, "Hey, we don't like the system. Maybe there's a better way." And you know, Benjamin Franklin noted that we have all these civic groups all across the country 250 years ago. And I think part of what we need to do now, 250 years later, is continue that tradition of just Americans coming together to find solutions. And so just being involved, staying engaged, and, learning how the system works is the beginning.
Absolutely. Absolutely. One little action at a time in your state, right? Because this is a state-run program. You can do a lot in the states. Our next question, maybe Les will tee you up on this because it deals with CMS and Congress, is from Ed Hazelmeyer, and he asked, the large-scale fraud found in Minnesota and other states appears to have been facilitated by a lack of suitable screening of providers by
Mhm.
before the state contracted them. Thoughts of how CMS and Congress should best address that. And I will add before Les jumps in on solutions is as we were writing this paper, we found states often contract with a contractor to vet the contracts. So when Les said there's a lasagna layer of contractors, that's what we're talking about.
Yes. So I want to reiterate the lasagna of contractors. So obviously, there's a Secretary of Health in every state, and they will contract with a provider to contract with a provider who is vetting, doing the actual vetting. So the eligibility is not by a government worker at any point. Um, and so when we're looking at how CMS can do some oversight here, one of the first things that CMS can do, and I think this is a non-negotiable, is when a provider is kicked off the rolls for any reason in one state, CMS should automatically do a search and see if that ownership group, if that social security number is registered to any other provider group in any other state. We are not currently doing that. So that is a first non-negotiable. And even CMS requiring that the Social Security number that is registered to an LLC or any business entity uh, has to disclose the entire ownership group of any ownership entity in any state would do a lot to disclose a lot of fraud. Secondarily, if CMS is looking at the TNSIS data on a quarterly basis to look at those fraud flares, and then referring it not only for the Center for Program Integrity and DOJ, but also to the state, and then requiring the state to have a third-party auditor, and then withholding funds specifically from those providers, that would do a ton. So those two actions right there, you're preventing the provider from skipping from state to state because they definitely do that. You're seeing the entire ownership group, and you're preventing that provider from just receiving funds from years and years. And you're requiring an investigation the moment you see a red flag. That's not going to catch everything, but that's going to catch a lot of what we're seeing right now. And we're going to continue to see a lot more.
And this will dovetail into our next question, but I think all of our panelists would also say we just need a pretty radical shift in being provider centered in how we run these programs to being person centered, right? A person who is hiring their own care isn't going to keep hiring a provider who doesn't show up. So TK is not going to keep paying for somebody who doesn't show up. So it's really important to put the structure of funding into the person's hands and decisions rather than the providers. And this is all. Betty Ann has a comment here who has a friend who has CP and has his own home and requires 24/7 support to meet basic needs. As the waiver in his state changed, common sense was lost. They determined he could not have overnight supports unless it was stated as a medical necessity versus for personal support and safety. This now increases budget as when categorized in this frame, and he now has to have at least an LPN, which is a more costly form of licensed care, versus staff who successfully and safely supported him for the past 10 years. And again, I think, Betty, and we go into the outcomes, as you say here, and the need to put it in the personal hands of the person needing care rather than filtered through this kind of licensed provider framework. Sarah, I don't know if you have anything to add to that kind of comment or and
No,
TK as well.
I mean, even just with Betty Ann on here, I think one of the things that we're exploring in these policy recommendations, and it's under the category of empower individuals and families, is for families to have more options for self-direction and the use of ABLE accounts as a vehicle for services to be provided for individuals so that they can direct and make their own choices as to their needs and their supports versus relying on a system that often tells them these are the providers that are available, and this is what is available in your area, and there's no creativity in terms of deciding what the best support is for that individual.
I would
TK,
say
can you
this,
speak to that?
yeah, absolutely. Because in New York, the program that I use has a exemption to the Nurse Practices Act. So the work that my workers do for me would ordinarily be, by law, required to be performed by a nurse. I believe this was a perfect illustration of regulatory capture and occupational licensing control of the marketplace. The work that my people do for me, first of all, I take responsibility for that training. It's not rocket science. It's basic like plumbing and just like biology that I feel comfortable training my people to do. I don't need a nurse. I don't want a nurse. A nurse doesn't want me. I would be their worst patient. Um, I take that as a badge of honor. But the point is, you know, I think we have to take responsibility for ourselves, and you can do that by deciding who comes in your home.
Hmm.
Well said, TK. Well, I think that is a perfect note to end on as we are at time here. I urge you all to take a look at this paper. You can see the paper and all of our other work at Able Americans, as well as personal stories in our Faces of the Disability Crisis video series at ableamericans.us. Please sign up for our email list so you can get all of the updates and continued policy resources like this. Thank you for joining us, and we hope that you will tune in for future Able Americans resources.